We have great tools to prevent cervical cancer. No woman should be dying of cervical cancer. We know how to detect it. We know how to identify women's risk. We know how to vaccinate against it. We know how to screen for it. And once a lesion is identified, it's a very slow-growing cancer most often, and so we have good tools to provide treatment as well. We see the disease persisting in settings where access to those tools is a challenge. On the Caribbean coast of Nicaragua, there's not a dense population in most of that geographic area, with a few notable exceptions like Bluefields, which was the geographic target of our pilot study. It's also a part of the country that's linguistically, historically, ethnically very different from the rest of the country. Nicaragua doesn't have a national HPV vaccination program. Prevention efforts are really based on pap testing or cytology. Our study was based on HPV testing. So instead of needing a provider and instead of having a speculum or a pelvic exam, our participants were able to collect their own sample. Then that sample was processed through an assay which looks for those high-risk genotypes of human papillomavirus. There's been a lot of research in a lot of diverse global settings about the acceptability and the feasibility of using HPV-based primary screening, and a lot of that has to do with the self-collected aspect of it. And pretty universally, women find it acceptable to collect their own sample. It's been found in several large studies and meta-analyses to actually help when having to go to a provider to get pap tested is a barrier for women. This has been found to help those women who are underscreened in a lot of, again, globally diverse settings. The World Health Organization has just committed to a plan to eradicate cervical cancer within the next 100 years. It's ambitious, but that's why new technology and innovative approaches are needed in order to try to meet those goals.
mHealth is short for mobile health and refers to health interventions that are delivered over a mobile phone or a smartphone, apps that support health care.
We worked with the Ministry of Health, the local Ministry of Health in Bluefields, to identify 10 health centers. We, in a period of 5 weeks, screened 1,791 women. Even with COVID, we're having a faster follow-up rate than previously the Ministry of Health had seen. Part of it is we're seeing areas where mHealth technology, mobile health interventions, really could help to facilitate communication and patient engagement.
Internet, like it or not, is the way that we get information, the way that we communicate, and the only way in many cases around the world that lower income people are able to access that incredible resource is through a smartphone.
I think that what was important about what we did was we made it regionally, culturally, linguistically appropriate in our approach. Once people do get screened and do get in the door in Nicaragua, sometimes they're lost to follow-up, which is true everywhere. But we're hopeful that by doing this pilot study and developing this mHealth intervention, we're hopeful that we're going to be able to prevent more people from being lost to follow-up and help usher them through the trajectory from getting your sample all the way through to treatment.